Good afternoon, everybody. My name is Laura Ravasi, and I am delighted to speak to you on behalf of Telix, where I am currently head of global medical affairs on new perspectives in prostate and kidney cancer. Just a little reminder that none of those products have yet received marketing authorization, and I will be happy to show you that they are currently being used on many clinical trials. Well, you may have heard of us already. We are an Australian company created about 5 years ago, and we are now spreading around. So we are in the US, in Europe, and in Japan. And we have already delivered about 12,000 doses to patients last year. And we are involved in 8 clinical trials with 17 countries, and we distribute up to 60 countries. So this is the pipeline of Telix at the current moment. As I was mentioning, we are keen to help any kind of patient, and especially on the unmet needs. So brain cancer is one of them, especially glioblastoma. And this is why we are developing phase 1 and 2 trials in diagnostic and curing brain cancer. But the focus of this speech is on prostate and kidney, because this is what is major interest for you. I would like to introduce you our paradigm, which is when you see something, you can go ahead and treat it. Well, this is not new, because for a long time in medicine, we have used a way to identify a disease before proposing a treatment. So this is very similar to the old traditional paradigms like CT or MR, except we actually are using a way to see the disease as early as possible, because we are going into not a morphological change, but a presence that is very peculiar, because it actually is overexpressed on the cell of the potential disease. How do we image this? Well, thanks to a tracer that has a radionuclide attached to it and is actually going to target that cell that is present in the disease. And once we have identified 1, 2, or any location, whether close or far away from the primary site, we can then offer a better patient's management to the way that we will treat the disease of that particular patient. And we apply this paradigm to our patients, because we would like them to be treated in a very accurate way. And before treating, we have to accurately stage the disease. In particular, we want to be precise, because the more precisely we treat the disease, the less side effects. But also we want to treat the disease wherever it can be systemically. So as I was mentioning earlier, we have a radioisotope that is attached to the ligand. That ligand can be an antibody or a small cell, a small molecule, sorry, that actually goes to a receptor that is in general overexpressed on the outer side of the cell that we are targeting, because that one is a malignant cell. And this is the reason why it is very specific. We can systemically administer this tracer to the patient, so it biodistributes all over throughout the vessels. Therefore, we will not exclude any part of this body. And you can see on the right side of the screen the 3 images that represent the images of, on the left-hand side, a prostate cancer patient that was imaged thanks to a compound that is called 951, and which targets in particular PSMA. Now, on the middle, we see a patient imaged with a molecule called 250, and this is a molecule that is targeting another kind of receptor that is overexpressed in renal cell carcinoma. And we can see as well on the right-hand side, the image of a glioblastoma that is again detected thanks to a molecule that is that has another target as well. And that is the specificity of our paradigm. So a few specifications on the current trials that are ongoing in our company right now. We have both a therapeutic and diagnostic trial for the metastatic clear cell renal cancer. And that is with an idea of diagnosing the disease with a radioisotope that is probably not as well known to you, which is zirconium. And it is currently ongoing both in Japan and outside Japan. And then a potential therapeutic trial to cure those patients. The reason for the zircon trial is because we would like to remind the audience, although you may very well know it, that some of the clear cell renal cell carcinomas are misstaged because they are sometimes diagnosed as an incidentaloma, and through a CT or an MRI that was not specifically done for this, and it's a renal mass that was not better identified. And then the patient has to undergo a kidney biopsy, which is invasive, and eventually be offered a surgical treatment. Well, we would like to propose a way of more accurately and less invasively diagnose our patients, or the patients who actually are bearing this disease, by offering a way to confirm that the disease is present and whether it is present only around the kidney or in other locations, for which a potential change in patient's management could be required. We are not only interested in diagnosing the patient, but also treating. So the treatment could be offered by using the same molecule, but then radiolabeled with a high energy radioisotope as the lutetium 177, for example, but also in combination with other therapies like immuno-oncology, because it is very important that we also think about combining our weapons. So the radiations that are delivered is a way to attack a disease, but immuno-oncology is also another way, and both combined could actually even further reduce the side effects and optimize the treatment for the patients in those conditions. Then, well, obviously, we would like to offer a possibility to the patients who are actually resistant to their first therapy as a castration of the metastatic prostate cancer that they actually are bearing. And we would like, in a second line, offer them a possibility of radioligand therapy. And we would like to see whether those patients are better off with this therapy, radioligand, or with the chemotherapy that is often proposed. We have now in literature very many responses on which, and evidences on which, the PSMA PET can actually be of better accuracy than the conventional imaging that used to be used with CT and bone scan. So for one exam, the patient gets many better results than two exams that were necessary. And it is not only less expensive for the society, but also much better for the patient because it actually is more accurate. So the point is now, how can we make sure that all the patients who could benefit from this PSMA PET can actually really benefit from it? And that's why we have thought about the many potential indications, not only the biochemical recurrence following either a surgery or a radiation therapy, but also maybe in primary staging for people who are at high risk because of their family history, for example, or a potential selection of patients with a possible radioligand therapy following. And why not also a way of monitoring whether the therapy that is being administered to the patient is actually a good one and there is a response to this. So those are other indications for which the PSMA could be beneficial. This is a very exciting moment because we would like to provide to our clinicians who are our partners a easy and fast way to actually help get diagnosing those patients very early on. And we prepared a kit that's a cold kit that's prepared in 5 minutes at room temperature. It couldn't be easier. And it's sterile, obviously, so that we can prepare on demand a gallium-68 label PSMA 11 for the purpose of selecting patients, monitoring, and understanding whether they're eligible to therapy for all prostate cancer patients who are overexpressing PSMA. And we would like to have the opportunity to work with you very much on this cohort of patients who is very, very big. And we would like to partner with all of you on this project and hope the market authorization coming soon at the beginning of the year 2021. So this is a very exciting moment for all of the patients who are going to be able to undergo a positron emission tomography imaging, because with the gallium PSMA 11 and the cold kit preparation, they will all have access in a very easy and fast way. Unfortunately, not all of the patients will have access to PET. This is why we have thought about an alternative to the gallium-68 PSMA 11 imaging. And this is with a product that is going to be labeled with technetium-99, and it is the HYNIC PSMA used with a SPECT machine. And that is going to be a very good alternative to the patients who cannot have access to PET, as I was saying. And you see on the right-hand side of the screen that clinically, it is of very great importance, all the information that is derived through a SPECT when you compare the image on the left to the one on the right-hand side. And clinically wise, the information is major. So the idea is the same as with preparation with the cold kit and access in a very easy way. The registry that we are behind is a noble, because the vision is to not leave any men behind. And we have collaborated with an international consortium of clinical sites who are already very experienced with technetium-99 PSMA. And we have a steering committee, and some of them may probably hear us now, and we are very proud of having them as our partners all over the world, because the launch is actually very effective, and before the end of the year, it is a go. So on this, we would like to help all the patients all over the world and have as many partners as possible with all of you. We believe in using the pharma and the clinical universities and academia to really partner up so as to get a patient a better life, a better quality of life, and a better way of treating the diseases. Thank you very much for your attention, and we will be for sure in touch. Thank you.